Hello. I invite all of you to take your seats, please. So at this time, it's a great privilege for me to introduce our next segment, a welcome address from Admiral Rachel Levine. Admiral Levine is a physician in academic medicine by training and now serves as the 17th Assistant Secretary for Health in the U.S. Department of Health and Human Services. She's also the head of the U.S. Public Health Services Commission Corps. Admiral Levine recognizes existing disparities in healthcare and how they lead to poorer outcome. She recognizes the unique healthcare needs of the LGBTQ+ community and the importance of working to reduce barriers to care, improve access, and providing affirming and culturally appropriate care. She fights every day to improve the health and well-being of all people and promotes diversity, equity, and inclusion in healthcare as a necessity to build a stronger foundation for a healthier future, one in which everyone in the nation can attain their full health potential. After graduating from Harvard College and Tulane University School of Medicine, Admiral Levine completed her training in pediatrics and adolescent medicine at the Mount Sinai Medical Center in New York City. Admiral Levine was a professor and is a professor of pediatrics and psychiatry at the Penn State College of Medicine. Her previous posts included Vice Chair for Clinical Affairs in the Department of Pediatrics and Chief of Division of Adolescent Medicine and Eating Disorders at the Penn State Hershey Medical Center. I should parenthetically add that in 2020, Dr. Levine was one of the persons I thought I would really like to meet in person because I saw her every day on TV as the Pennsylvania Secretary of Health, where she was a voice of reason, calm, and credibility in helping coordinate the COVID response in that first year of the pandemic. Dr. Levine.
Hello, I am Admiral Rachel Levine, the Assistant Secretary for Health at the United States Department of Health and Human Services. Thank you so much for inviting me to speak at the National Comprehensive Cancer Network Patient Advocacy Summit. I was called to medicine, as many of you were, by my desire to help people and to work towards the common good. What makes us, physicians, nurses, and other medical professionals, is our choice to spend our days, and often our nights, helping our fellow human beings live well. As we all know, medicine is about saving lives, but also about improving the quality of life. And the work that all of you do in cancer prevention, research, and care is critical to the health and wellness of all of us who live in America. As healthcare professionals, we learn to treat patients without discrimination. We work every day to benefit the sick, to protect people from harm, and we work to make our community whole. We can do that with medicine, and we can do that as well with warmth, empathy, compassion, and understanding. We also know that there are disparities in health caused by barriers to care and fear of mistreatment that can lead LGBTQI+ individuals to experience cancer differently. It is critical that we remove barriers to preventative cancer screenings. It is also important that we understand that LGBTQI+ people with cancer diagnoses need culturally appropriate and affirming care. Providers and advocates should understand the unique challenges for these communities. As we move forward together, all of us must ensure that no one has to face cancer alone, and no one has to delay or avoid cancer screenings or cancer care because of fear of mistreatment. I would like to highlight the importance of diversity. Diversity for a medical school, a medical center, in government, in business, and really every organization. I strongly feel that diversity, equity, and inclusion, in all of their myriad and wonderful aspects, should be welcomed and actually celebrated for the way that they strengthen and enhance any organization. I encourage you all to embrace and emphasize diversity in your current roles. Diversity makes us stronger. Each person has a different perspective, different strengths that they bring to make the whole community stronger. The time is now for our country to continue to move the bar forward for diversity. There is more that can be done and should be done to address opportunities to improve patient care for LGBTQI+ populations across the lifespan. We are in an exciting time focused on diversity and health equity. And when we say health equity, we mean health equity for all. This includes expanding the definition to include the LGBTQI+ community. Transgender persons suffer significant health disparities. There are many barriers that the community faces: lack of knowledgeable providers, overt discrimination, health system barriers, and more. We are working to address these issues throughout HHS, and we're just getting started. We know in medicine that one size doesn't fit all, and just as precision medicine is the future of healthcare, that also applies to the LGBTQI+ communities. Research into our unique needs is essential so that no group is left behind as we create a brighter, healthier, and more equitable future. This inclusive approach to governing, it gives people a voice, a chance to affect change, and an opportunity to help people understand the diverse needs of our nation, including our health needs. We know that there are many groups that face unique and increased health risks. We must close disparities in access and outcomes, eliminate bias and discrimination, and address the systemic barriers, including the barrier of systemic racism, that have contributed to historic inequities. All Americans deserve services that are timely, affordable, accessible, equitable, and high quality. This is, of course, important when it comes to cancer prevention and cancer care. As a nation, we can do better, we must do better, and we will do better. I firmly believe that as a society, we have not made progress unless we have all made progress. Acts of intolerance damage our nation's health and well-being, including, of course, our mental health. We need to continue to work against disparities in health and barriers to care until everyone living in America can achieve their full health potential. Thank you.
That Admiral Levine could join us here today. And Admiral Levine used the term barriers a few times, and Admiral Levine is correct, but I might add or suggest that in considering the title for this panel, sometimes the word barriers is a little too passive for what's really going on out there. And these communities face sometimes overt hazards, and as we learned again recently and all too often, sometimes violence. And so there are many layers to what these communities face. And so if you'll kind of join me in taking a broader connotation of barriers, we're going to proceed, and I think you'll hear some of these insights, relevant insights from this group. So the panel is entitled Breaking Barriers, Identifying and Addressing Unique Cancer Needs of LGBTQI+ Patients. And I'm going to ask each of our panelists, starting with Chastity at your far left, to just introduce themselves, just briefly, kind of name and affiliation, and in a sentence or two, how did you find yourself on a panel of this title? Chastity.
Thanks, Clifford. I get to follow Admiral Levine. I mean,
not bad.
not for nothing. Hi, everyone. Good morning. My name is Chastity Burrows-Walters. I'm here from Memorial Sloan Kettering Cancer Center. My pronouns are she, her. At MSK, I'm the Director of Patient and Community Education. I'm also the founder and the sponsor for our LGBTQ Clinical Advisory Council and a steering committee member for LGBTQ+ Pride, our employee resource network. Most of my work is around communication, so I spend a lot of time both researching and training clinicians specifically around inclusive care and LGBTQI+ pride.
Thank you, Chastity. Bláz.
Hi, everyone. I am delighted to be here with you today. My name is Bláz Bush. My pronouns are Bláz or he, and I am the Executive Director for the LGBTQ+ Health Program at Stanford Medicine for all of 4 months now. in this inaugural role, so thank you. I may appear on your sheet as Terrence Mays, who I find myself here covering for, which is fine. He let me know whenever we were going to meet to prep him for this event, but I think it just worked out that I got to be here. I will say that I've been doing LGBTQ healthcare work for 13 years now. I was in New York at Callan Lord Community Health Center as a director of care coordination, and then switched over to higher education at the University of Louisville, and now at Stanford. So I bring my experience as a case manager and overcoming barriers or intentional blockades to LGBTQ healthcare and social services and health disparities, as well as education and teaching and how we can build a multiple pillar approach to LGBTQ healthcare across the lifespan. So.
Thank you, Bláz. Over to Paula.
Hi, I'm Paula Chambers-Raney. Thank you for having me. Excuse me, I'm a stage 1 colorectal cancer survivor. I believe that implicit bias almost cost me my life. And so I survived that. And I'm here today just to share my story, how my cancer was found, how my wife of 37 years and I have navigated being gay and me being sick and the healthcare system. And I'm an advocate for change because I know it can happen and I know that it needs to happen. So thank you for having me.
And thank you for being here, Paula. Archana.
Good morning, everyone. My name is Archana Pathak, and I currently serve as the Interim Director for the LGBTQ Research and Advocacy Center at Virginia Commonwealth University, the Q Collective. I also identify as a member of the community. It's quite an honor to be on this panel with such distinguished members.
Thank you. And Mandy.
My name is Dr. Mandy Pratt-Chapman. I am Associate Director for Community Outreach and Engagement for the George Washington University. I also sit on the ASCO Sexual and Gender Minority Task Force, and I am also a founder of a new nonprofit called Radical Inclusivity. There's a table out there with little plantable seed cards. If you want to plant some herbs or some wildflowers, grab some. And I came out at 32, and for the first several years, didn't really know how that would shape my research career. I was already involved in post-treatment cancer survivorship, sequelae, and building programs in that space, and access to care issues. And I went to my dean and I said, I think I want to focus on the queer space, but I don't really know much about how this actually applies to my health yet. And then from there, I've been focused in that space. So happy to be here.
Thank you so much, Mandy. We have a lot to cover, and we've agreed with our panelists that we'll try to keep our commentary short so we can get to as many of these issues as possible, but there is a lot to cover. Let's just start out with those challenges, and Mandy, you just kind of set it up really nicely. At a high level, Mandy, tell us, if you can, what are the main challenges and experiences that are faced by the LGBTQI plus community pertaining to bias and discrimination? Can you kind of give us the nuggets on that?
Yeah, I mean, I think we're so socialized in normative ways. I mean, I was so socialized as being heterosexual that I felt like a straight person who dated women for about 2 years. When I came out, I think that lack of representation on intake forms, in electronic health records, although that's changing, as Scott mentioned. Lack of awareness on the part of patients and providers about risk. Unique risk and risk the same as other populations that might be perceived as lower, for example, HPV. And things like, women's centers, gendering kind of the names of centers or buildings, and the preponderance of pink, and the highly gendered ways in which we kind of refer to cancers, right? Instead of looking at anatomy or organs and how that might drive our health conditions as opposed to our pronouns or our anatomy or our kind of sex assigned at birth.
It's interesting. It goes so far as the color of paint and wallpaper, apparently, as you just mentioned. And these are just some things that most of us don't even consider. But it really does set up a kind of a potentially biased or stigmatizing environment. So Bláz, I wonder if you could comment in particular on the issues of isolation and separation, and then intersectionality. Could you hit on those?
Yeah, absolutely. So I think one of the things, and I think Mandy set this up perfectly, but there's so many nuances to the LGBTQ community that I don't think we talk about enough, and I don't think when we prepare cancer care and treatment or those environments that we include these. So, for example, if an individual comes out to their family and their family isn't supportive, then you've lost your family as a community of support. And what do we know about anybody facing a chronic illness, but especially when it comes to cancer, you need an extensive support system of caregivers and an important community. But I find for LGBTQ folks, you may be disconnected from your family. Whenever you get sick, you may be disconnected from your chosen family. Our social spaces tend to be out at night in bars where we can find each other, which we know are also under attack right now. And so being sick for an LGBTQ person can mean losing your community that you fought so hard to be a part of, and then not having spaces to come in and connect with them. And then you look at cancer care centers, which may be very heteronormative, and say, you know, we have support groups for husbands and wives. Okay, well, I doubt you're going to be inclusive of me and my partner in that space, even if your intention may be to be fully welcoming. You've set it up so I don't feel welcome from the beginning.
So these barriers and walls sort of appear out of nowhere, setting folks apart from their colleagues, their friends, their loved ones.
That's right. And then you brought up intersectionality, so I also want to say you add in layers of maybe disability or race, which have their own complexities when it comes to LGBTQ inclusivity. And so you may see even further isolation whenever you start to add in these intersecting layers of oppression.
So it's almost exponential increases in oppression every time you add another barrier. Oh, good gosh. Want to ask a bit about this from the provider side and go to Chastity and Archana, and as a putting you on deck, Paula, because we're hoping that you'll talk a little bit about screening for cancer. And so having heard the view from the providers in just a moment, that might provide a good platform from which to take this off. And so Chastity first on the provider perspective, easy, hard, sources of bias, and then same for Archana. Chastity?
I think we need to be very aware. You know, when people walk through our doors, they're coming in with a lot of experiences, right? What we heard from Bláz, and a lot of trauma oftentimes. And I think that creates an awareness, almost a hypervigilance. And so when someone walks in, we've got to be thinking about, like, they're noticing, is there a stare? Is there a whisper to a colleague, right? Does that bathroom just say male, female, right? And all of these things add up. And it just really, I think, it creates a distance. And I think the extent to which we can acknowledge that that's happening for someone really can help us to open ourselves up to, wow, like this person isn't starting from ground zero. We may have years and years of this coming through our doors. So let's step back and really be open and welcoming.
Chastity, how well prepared do you think clinicians and other providers are to sort of cope in this kind of environment? Are they trained or otherwise or educated to see these barriers that are invisible to others?
I would have to say not, and I think my colleagues would agree. I think there are a lot of efforts happening right now. I think those of us on the panel are folks who do a lot of these trainings. You know, one of the issues that we find is you can't do a one-off training, right? I can't teach you everything there is to know in an hour. So that's one issue. The other issue, I think, is that when you're not seeing something a lot as a clinician, whether it's a particular disease, whether it's a person who may be non-binary, clinicians get nervous. We know our comfort zones. We know what we know. We're super, super subspecialists now. And so when we're faced with something that we don't see a lot, we get a little panicked. And sometimes we make mistakes when we're panicked. And so when I'm doing trainings, I'm often saying, not if you misgender, when you misgender. Let's talk about what you're going to do. Because I think we need to acknowledge that this is going to be a learning process. So one of the things I really advocate for is integrating these concepts. Yes, everyone needs training, and we need to understand some basics. And we need advanced training, you know, for those folks who are doing work specifically in this area in particular. But we need to integrate issues that involve LGBTQI plus persons into every training we do. You know, why are our simulations always cisgender and I don't know, like that's not what the world looks like.
That's a great setup, and again, you're sort of outlining the environment as it has been, and to a great extent what it still is. Barriers aplenty. Archana, I know you've taken a careful look at this, so from that side of the exam room, as it were, what are we seeing?
I think that so much of this work is that we expect that we should know everything. We can't know everything. It's a rapidly evolving community. Like the ways in which we talk about ourselves and with ourselves continuously changes. Language evolves. Our understanding of what it means to belong in the community is evolving and continuously organically growing. It's a complex and diverse community, right? So it's not just, the umbrella isn't a one place, it's a many places. And I think that that is a part of it. I really encourage folks when I talk about these issues to understand that the goal isn't that you will know how to do it. The goal is that you approach things from a place of assumptive compassion, right? When we walk into the home of somebody who has lost a loved one, we don't always know how to act, but we absolutely know that we will find a way to have compassion. And we will understand that whatever way they react to us, they're coming from a place of grief. So we're not going to take that. That's not a personal thing that's happening to us, right? In the same way as when we bring people into care spaces, they are coming at from a place of stark vulnerability. I don't want to be thinking about, do you understand that this person who's standing next to me is the love of my life, and I can't process in my brain right now. I don't care how many degrees I have. I need you to let this person sit here because they are my eyes, they are my ears, they are the person who's gonna help me make sense of everything that's happening to me, and I don't wanna educate you. Even if you are the most well-meaning person, I don't wanna explain my relationship. I don't wanna go into, let me just be a vulnerable human trying to face a really scary time. And I think that when we can, and that happens not when we make everyone flat, but when we acknowledge and respect those differences and let them be the wholeness of who we are.
You know, stark vulnerability and assumptive compassion. 2 points to take home right there, everybody. Thank you very much. Well, Paula, in your self-intro, you referred to a bit to your own experience, and I wonder if you could share a little bit about your observations or insights regarding cancer screening, whether from a population standpoint or perhaps your own, as you wish, but please do share some of those insights with us. How does that roll out?
Well, I can just speak from my experience. What I knew about cancer screenings in my community, I came out at 14, so I've been in this space a minute, and the cancer screenings that I knew about that were offered to us in our local clinics were the colored ones, right? The pink cancer screening for the ladies. And when I got diagnosed, I was misdiagnosed for over a year with colorectal cancer. My tumor was found in the emergency room.
At what age, might I ask?
I was 44. So I didn't know about colorectal cancer screenings at all. I knew that I was supposed to get a mammogram. And so, you know, when I was diagnosed with colorectal cancer, I was like, what is this? Why have I not heard about this? I have had many HIV screenings, right, when I go to the local clinic, but no one has talked to me about the other cancer screenings that I need to be doing as a gay lady, as a black lady, as a human, right? And so I just didn't know what I didn't know. And I know that our communities focus on whatever the major issues are. I'm from Houston, in our area, but we have in Houston whole cancer areas in the city where people live and are diagnosed with cancers just by where they live. And those populations are mostly black, they're mostly brown and black folks, they're mostly people who don't have a lot of money. And so the screening aspect, just in the LGBTQIA plus community, in where I live, it's not varied and it's not wide enough. We're not talking about all the different cancers that we should be screening for within our communities. And that is something that it just needs to be talked about. We need access, we need acknowledgement, and we need awareness.
So, Paula, can you tell us a little bit about the timing of the screening and the clinical response to it?
The timing of the colorectal cancer screenings.
Yes.
So
For you.
for me. So my colorectal cancer screening never, you're talking about my situation, right?
If you please.
Yeah, so I'll quickly tell y'all what happened. In 2014, that whole year, I was sick. It started off with tummy aches and, grumblings and gas and things like that. So I saw a doctor at my local, I went to the county hospital because I couldn't be on my wife's insurance. We weren't legally married in Texas. So my wife has always had different health care than me. She's always had a provider, and I've always been at the local, because of the jobs we worked. I was misdiagnosed by PCP several times, and I kept getting told I had hemorrhoids, I had anemia, but nobody checked, nobody gave me any screenings. When I started to see red in my stool, when I started to lose weight, I was just told it's probably IBS, or it might be this, or it might be that. So I was never offered a screening anywhere. I went to urgent cares, I went to emergency rooms. In the emergency rooms, we were told we were drug seeking. One doctor told us, I can't treat you because you're going to hell. Oh. So it just snowballed into where I ended up they found my baseball-sized tumor in January of 2015 in the emergency room at the county hospital. So I had an emergency resection. I lived, and I was really angry. From that anger, I had to take it and turn it into something else. And I started talking to other people about this, about their screenings. Mostly, I know gay people, I know black people, so that's who I talked to. And the ones that I met in the colorectal cancer space were all telling me kind of the same things. They were ignored. I realize some of this has to do with age, but I've got used to being treated bad in healthcare systems, period. I got used to people telling my wife and I, she can't be in here, she can't help you. And I also my wife's Caucasian, so I also got to see something in the emergency room I had never seen before. One day when a doctor told me, he came in the room, he saw me bent over like this, he looked at me, he looked at my wife, he looked back at me, he looked at my wife and said, just so you know, I don't give drugs in this ER. My wife turned around and took the guy outside, starts yelling and screaming, and another doctor comes in. I didn't know you could do that, but she did.
Oh my gosh. I'm having to recover from my gasps. So, thank you, and good gosh. Mandy Pratt Chapman, you've studied this, you've looked at this. How do you react to what Paula just conveyed, and even in the broader context of more population-based insights?
Yeah, thank you for the opportunity. I wanted to just, there were two major points that I wanted to make coming out of the evolution of this conversation. The first is that bias isn't always implicit. Sometimes it's very explicit. And three examples of that I'll quickly share. A good friend of mine recently went through an entire year of very heavy menstrual bleeding, going through a package of pads a day when she was on cycle, and hadn't been to a gynecologist in 20 years because she was told that since she had only had 2 female partners ever, she was basically a nun and didn't need to see a gynecologist. So when she actually went to the gynecologist said to her, wouldn't give her anti-anxiety medication or any kind of analgesic, and had trouble actually doing her PAP. It turned out she was HPV positive, did have an abnormal PAP, and when she went back in after having trouble the first time, the gynecologist said, I can't believe I ever reached your cervix before. These are things you don't want to be told when you're, and it turns out that she had uterine fibroids and is getting hysterectomy, so it was not cancer, thankfully, but that kind of treatment should never have happened. Secondly, I was asked to speak at remotely at a conference in another part of the world, and I get a lot of invitations to speak. When they reached out to me, they just said, we read some of your papers, we'd like you to speak, blah, blah, blah. And so I was like, well, okay, I could talk about patient navigation, cancer survivorship, but I want to talk about queer health, right? So I said, can I talk about LGBT health equity? And they said, oh, no. Oh, no, we must get on a call. So they had 4 people call me in the evening the next day to make sure that whatever I was going to talk about wasn't going to talk about queer health. And the irony is that the pharmaceutical company that wanted me to speak was the same pharmaceutical company that sponsored an LGBT health equity project in the US because it was more palatable. And I couldn't use the materials that I had developed from that pharmaceutical company on a US project when I was talking in this other part of the world. The third and quick story is I was talking to almost 1,000 pharmacists, 976 to be exact, because sometimes I remember weird numbers. And one of them, and I was not even talking about queer health. I was talking about our clear and documented history of 400 years of racial segregation, slavery, redlining. And he said that my talk was so biased that he was going to get off the call before he vomited, and then emailed me and asked me if all queer people worship Satan and why I was trying to convert all of the pharmacists politically. I said nothing about politics. So all of those are pretty explicit bias scenarios. The other thing I want to just point out is that there are clinical gaps too, even though communication is critical. Bedside manner is critical. Compassion is absolutely critical. There's also clinical knowledge that relates to queer communities that clinicians are not trained on. A friend of mine asked, will you write a paper in this special issue for this journal on radiology, radiation oncology, and gender, queer health? And I said, sure, well, let me see what's in the literature. 0. There's nothing on radiation oncology and queer health. So I said, but I'll do a study. So I interviewed 16 radiologists and radiation oncologists, and they were remarkable on kind of their experiences with transgender and intersex patients. And there were remarkable needs that clinicians are not trained about, most notably that if you have radiation in the pelvic region, that you probably can never have gender corrective surgery because of the damage to the tissues.
And we are going to hit on that issue. Thanks for reminding me. Yeah.
So clinical competence is also critically important in addition to cultural competence.
Thank you for that, Mandy. I'm just wondering, Chastity, Bláz, Archana. Can you take these highly personal and personalized stories, some of which are anecdotes, and tell us if these are just kind of random anecdotes or are there population impacts more broadly in your view? Chastity? Are these just one-offs?
These are not one-offs. I'm watching nods all over the room. These are not one-offs. This happens every day. It happens across the country. It happens across the world. And that's why we're here.
Yeah. Archana, one-offs?
Well, I'll dispel the myth of the one-off. I've also been told that my wife can't be in the room. I've had nurses walk out and say, I won't treat you. I have been told they'll call the cops because I've said, if she can't be in the room, I need to record this because I'm too scared to understand what's happening. And I've been told they'll call the cops because I'm violating HIPAA. I work in DEI at a university where we have a health system. There are lots of HIPAA violations. This is not the one that we're going to call the cops on, right? So it's not a one-off. There's 2 people on a panel who've never met each other, who have never been in the same spheres together. You know, I went through going through menopause, went to an OBGYN who I fired. Again, the privileges, the intersectionality here, having the privilege of being from a community that is well-versed in healthcare in the United States, right? I knew what I could and couldn't do, who told me, you don't use it, let's just take it out in reference to my uterus because I was struggling and having a hard time and dealing with some pain.
I don't. Also, I'm sorry.
Yeah, no, so I'm just saying that, like, both examples, there's already a triangulation happening. But it doesn't matter to me if it's a one-off. I don't understand how we create healthcare systems in which anyone is not seen as a whole being and where our primary focus isn't figuring out how to provide a quality of life. That is a failure of medicine.
Indeed.
And I just wanted to note that it's hard to even answer that question just because we don't systematically collect sexual orientation and gender identity data, right?
No.
So when we're talking about population level, no, it's not a one-off, but when we're talking about population level impact, we're still really struggling to just, even when these fields are in our electronic health records, are people trained? Do people understand why they're important? And so we're starting to move there because of the NCI supplements. We're starting to move there because of progressive leadership. But we can't really say beyond smaller studies what the population impact is because we don't have good data.
So, don't want to leave that, Mandy. So you're saying then that we can hardly address the problem if we don't have the right data fields?
We can't diagnose the severity of the problem or what the specific types of interventions we might most benefit populations if we can't stratify the data. But I will caveat that with, we put ourselves in boxes way too often. So even though I'm such an advocate for sexual orientation, gender identity data collection, we assume so much when we put ourselves or other people in boxes. Do you want to be put in a box? I don't want to be put in a box. I'm a whole bunch of things, right? So yes, we need to collect these data, and we also need to not simplify. We need to not be reductive, not stereotype. And we also, one thing that hasn't come up yet on this panel, we also have to focus on resilience, right? Not just the disparities. So what can we learn from subpopulations where there's resiliency, and how do we apply that so that we can do better?
Point well taken. Bláz, a couple kind of terms come up, and I'm hoping you can kind of help define and explain their roles here. Screening, speaking of screening still, screening challenges for trans men, and gender dysphoria, and perhaps misgendering. Can you kind of give us some clarity on the role of those concepts?
Yes, and I do want to start off, fellow Texan from birth, and thank you for sharing your stories. I hate that happened. I want to start with misgendering because I thought about this, and I just want to throw this out for everybody in the most loving and gentle way to this conference and everybody here. But how many of us, show of hands, know that using pronouns, introducing pronouns, including pronouns is a best practice? Show of hands. Raise them high. Almost everyone, right? I want to push us to say that not only do we know that it's a best practice, but it must be practiced. So on our badges here today, we don't have our pronouns. On our speaker sheet, we don't have our pronouns. And again, I'm love to the summit. This isn't the only place I've been and spoken and engaged with where we're not practicing what we know as a best practice.
Bláz, push back on it. You got to tell us why not doing that is injurious.
Yes, I'm glad. Just ready to get there. Because it goes all the way through our system. So if we're not doing this here, and we're not norming it here in this space, so we don't take it back and norm it, we're in our conference rooms, in our organizations, we don't norm it as providers when we're talking to our front desk staff, and our colleagues, and our nurses, so that everybody's doing it. I mean, even within some of the executives in the LGBTQ plus health program, I hear the misgendering our non-binary colleagues. And they're like, oh, Bláz is here. It's fine. I have a good rapport with this person. They're like, Bláz is here with this cattle prod every time I misgender, saying they, them, they, them. And I'm like, yeah, because we know, we're the leaders in this space, and we're not practicing it. And so when we talk about the patient access, when we talk about this, best assumption case, if we're not practicing it, then it's not going to become normal, and we're not going to create those environments. We're not going to create environments where when I go with my partner, they say, oh, it's so nice that you brought your brother to the clinic today. Mm-hmm. Isn't that lovely? I'm like, well, this is about to get real awkward for all of us. Similar experiences. In the same way, I also have had to advocate to demand getting an HPV vaccine. I've also had to advocate to demand to get colorectal screenings. So, and that's a privilege of myself, right? I work in this field, and I'm on panels like this where I hear the importance, but most of my community is not in this space, right?
So, Bláz, a specific item here, again,
oh yes,
in cancer, in screening, gender dysphoria, just kind of, in case not everybody kind of gets the roll up, and
right.
One more I'm going to throw at you is on the screening sheets, heteronormative screening sheets. Can you hit on those?
Right.
Please.
So at University of Louisville, somebody approached me to go over the cancer screening form for around chest cancer specifically and wanted my feedback. So as I was looking over the form, I mean, right off the bat, right, everything is gendered language, right? What's your history on your mother's side and your father's side in your family? Which we know we're looking at genetics here, and that's important, but we're already putting very gendered language instead of parent 1 and 2, or like share the gender of the parents, for example. And then we had, like put on this body where you've seen any lumps. And of course, this is a body with breasts. And I said, well, what about bodies that don't have breasts, right? Other people can have chest cancer, or if you're a trans man, you may have had, your breasts removed, and so it's a chest with chest scars. Where are they going to put lumps? And how important is it that they see themselves reflected in this? And then on the gender dysphoria, gender dysphoria is the discomfort in whenever you hear something or experience something that doesn't co-align with your gender expression. For example, like for myself, I hate being sirred, I hate being Mr. That doesn't feel good. That feels like dysphoria. On the resilience case, I think we can also talk about euphoria. I love my name Bláz, and it's euphoric to be referred to as Bláz, more so than Sir or Mr. So that's an example of euphoria. So when we're working with patients, right, like seeing a chest when you're going in for a chest screening with only breasts will feel dysphoric, right? Because that doesn't look like me, that doesn't look like my body, and you're assuming that would be what my body must look like. But how euphoric would it feel to see a body that would match you, or to see imagery in the center that matches you, to see imagery of a black couple wife in the center, or a black and white wife in the center, for example, that reflects your family and your relationship and how euphoric that would feel.
So Bláz, this is so very helpful, and I hope we appreciate the importance of recognizing, identifying, and clearly sharing in routine use this vocabulary. We're not set up to do that. Archana, and then I'm going to come back to Chastity on this issue. Archana.
There's a couple of things I want to add to what Bláz was just saying that I think are super important. In terms of sharing pronouns, I think it is very important that those of us who identify as cisgender do that. It opens the door of safety, and that becomes very important. It is a scary thing for individuals who identify as transgender. Some may pass, some may not, right? And to have to speak that into the space, because it does change the healthcare experience. It matters. We have to talk whether we have to identify the sex assigned at birth for a variety of reasons, for healthcare reasons, right? That immediately throws a person into dysphoria. Because now I have to talk about something that was in and of itself maybe the most dangerous part of my existence. And so when we're cisgender, it's not just, oh, we're letting them tell us who they are. They can do what they want. When I do that, I'm saying to you, I understand that who you are, we're gonna have to talk about that in a way that might be painful for you, right? And I think it's also important in terms of when we talk about screenings, it's about touch and touching the body, and this is again about dysphoria, when we have to talk about that body part, or when we have to touch certain body parts, those spaces are, and we would do this in heteronormative and cisgender spaces. In a cisgender space, we talk about best practices. Oh, I'm gonna say, oh, I'm gonna touch you here now. This is not hard. We're not asking physicians to do things that they don't already know how to do. That's the part I think that gets lost in these conversations sometimes. That this isn't, oh, these people over here do these things. I think that happens in screenings, right? Yeah. Well, if you're having, men who have sex with men, then we're gonna stereotypically say these are the kinds of conditions that come up. Women who have sex with women, these are stereotypically the kind of conditions that come up. Our sexual identity isn't about who we have sex with. In the same ways that heterosexuality isn't about who you have sex with. It's about how you move in the world. It's about how you understand and experience intimacy. It's about how you know yourself to be.
So Archana,
add one thing
on
to
this
that?
point, sure.
Yeah. I just want to, in addition to gender dysphoria, I don't know what the word is for this, but to your point about assumptions around women who have sex with women, men who have sex with men, I just want to reiterate that there's a lot of misunderstandings around cancer screening for women who have sex with women. I have a friend who's a very self-proclaimed old school butch lesbian, never been to a gynecologist, played DC Divas football. None of her colleagues have gone to the gynecologist. And there's this perception that, oh, if I don't have sex in this way, I'm not at risk for that cancer because of the way that I have sex.
Yep.
And that's totally, completely false.
Yep.
Oh dear.
Yeah.
So I'm going to set up Paula one more time, but I'll give you a few minutes on this. We haven't talked about this. Archana talked about touching. And medicine is, I mean, one of the phrases is laying on of the hands. Mm-hmm. And you talked about things like body parts. And so I'm thinking in this sort of clinical crucible where physical touching of body parts is part of what's supposed to go on, where might that go awry? Paula, I'm setting you up for that. And before we go to you, Chastity, how does this all impact clinical decision making? I mean, I'm trying to kind of thread this together. We talked about data collection, we talked about questionnaires and surveys that are set up as heterosis-normative. How does that affect downstream, or how does that inform or misinform clinical decisions which affect healthcare outcomes?
How much time you got?
Well, give us your news.
Yeah, I mean, data is everything, and Mandy hit on this a bit. I mean, I think the reality is until we have standard, systematic data collection across different centers, we will never have the information that we need to develop and implement the targeted interventions that we need to inform evidence-based care. I mean, we collect SOGI data where I work.
Got to say what SOGI is.
Apologies. Sexual orientation and gender identity data, right? And so, but even collecting at one center, that's not enough. It's going to take me a really long time to know everything I need to know, for example, about the gender diverse community. But if we're all collecting it in the same way, now we've got this larger pool of data, and now we start to get the information that we need. This is a cycle. When we don't have data, we don't get funding, right? Because it's hard to make an argument. We don't have funding, we can't do research. When we don't do research, we don't have the evidence we need as clinicians to practice. And when clinicians don't have evidence, we get kind of uncomfortable, right? We lose confidence. And then that feeds back to the disparities, because now you're talking to a clinician who's clearly fumbling a bit, trying to make their way through this encounter. That feeds back to the disparities, which we can't articulate well because we don't have great data.
Point well taken. Thank you. Bláz on that.
I'll just say something on that real fast, and it's a call to action for everybody in this room. There are major electronic health records out there that have SOGI collection data as a module that you must buy to then add in, and somehow, as we know how complex these systems in, build it in after it's rolled out to try to make sense, make it sure it's billed right, make sure that pronouns are seen next to the patient name. Why this is not just standard base protocol that these are rolling out with is a problem. And
You
I
got to
think
pay
we all
extra?
need-
Did you say you got to pay extra?
Yes.
Yeah, right? You have to pay into to even get that module. So we have a financial barrier for some institutions, right?
Yep.
And then even just the workload of then back end building that piece in, which we all know should be a best practice, is a huge problem. And I think we all need to be pushing weight to say, this needs to be part of the standard set that's already built in.
Thank you. Any further comments on the data angle here? The data, the survey, the data collection, coding
And
angle?
the training of front office
That's what
staff.
I was going to say.
The training of front office staff on how to utilize that data effectively. At Virginia Commonwealth University, we've incorporated the collection of name of use without having to prove that you've changed your name. And this is at the university side, not on our health campus side, or not in our health system side quite yet. We're working on that. But part of that is training people and saying, you know what, people's legal first name, that works like a social security number. You don't go saying that out loud everywhere.
Yeah, and training on how to use the data, but also how to ask the questions and how to respond if people have questions.
Yeah.
I was talking to someone, I don't remember who it was, but I thought it was fascinating because she was telling me that, it was during an interview for another study that I'm doing on sexual orientation, gender identity data collection and difference makers across oncology settings. And she said, the turning point was when my cisgender male patient said, oh yeah, I don't want to be called Jonathan, I want to be called John. Thank you so much for asking what I want to be called. And that's when everybody said, oh, it's okay to ask what people want to be called, right? So it's not always just about the queer population. Sometimes what we're recommending is good for everyone.
Another point well taken. Thank you.
So
Archana, one more.
I'm going to wrap that. So legal scholar Dean Spade says this all the time. He talks about trickle-up social justice. And that is that when you do the work that serves the most vulnerable population, every population that's slightly less vulnerable from that will benefit from that. And that's what we found. All of a sudden, the name of use field, they thought, oh, we're going to do all this work, and it's going to be the 5 people who don't want to be dead named. No, everyone is using the field because people have nicknames, they have cultural names, they have anglicized names, they have all kinds of things. And so when you do it for the most vulnerable, you benefit everyone.
Even divorcees. I just have to throw that out.
Oh, yeah.
Thank you,
wasn't gonna
Blaze.
go there,
Thank
right?
you. Just as a reminder, if you have a question, I think you've got note cards on your tables. We'll try to get to some of those as well. So if you have a question, please do write it down. Kind of raise it up a little bit so some of our staff can identify it. They'll bring it on up here. I see a couple already. Thank you. Paula, when Archana was talking about sort of the touching part, like your eyes opened up a little bit. And I know that you had so many interactions with so many patients around the country on that. Can you share with us, whether it's personal or across the people with whom you've worked and whom you've heard, on the exam room experience?
Yeah, the reason my eyes did that is because I remember the first time I took myself to the doctor. So I've been on my own since I was young. My family just said, we're not having this. So I made the decision, and my wife and I have been together since I was 16. So I've always had really bad menstrual cramps and things like that. I went to the local county hospital in Denver, which is where I'm from. I was about, I think, 16, and that first experience was with I wanted to see somebody, what can I do about this? And it was an OBGYN, it was an older gentleman, and I was like, oh, I'm gay, and this and that, and just the minute I said that, the whole exam went downhill, and I remember that specifically because his touch was rude, he was dismissive, he was, it hurt, and it just, from that time on, I was afraid to have screenings. And I've met other people that share these sort of stories with me. It's about the touch. It's if I tell you who I am, if I come in, if I'm a trans woman and I come in just feeling pretty that day and I want to look dressed up going to the doctor, I'm scared to come in as myself, so I'd rather not come in. And I hear this over and over and over.
So you don't even appear for the screening, which would delay any detection, et cetera, et cetera. Is that?
Yes, and so it happens more than you think. I've done it myself, unfortunately, and I didn't realize these patterns until I was diagnosed with cancer. I realized that there were times when if I was in pain or something was wrong, I just didn't want to deal with all the extra that comes with it. Do I have to say this? Do I have to do that? How are they going to treat me today? Am I sir or am I ma'am? Do I have to put this wig on? Do I have to put that shirt on? Do I have to dress up so they take me seriously? Yeah. A lot of people are delaying seeing doctors, getting routine screenings because they don't know how to come in and present who they really are and what's going on. If I tell you that I have this kind of sex, and I'm worried that that kind of sex might have led to this, well, if I think you're going to judge me, I don't want to tell you anyway. Yeah. So it's frustrating, but I've seen changes, and I want to say that I have. I've seen people listen to gay people in these situations. I've seen clinicians and I've seen healthcare providers start to listen to us because we're dying from these things. When we delay our screenings, we get all kinds of other unintentional side effects from that. And death is one of them. And I want people to realize that if we don't have access, acceptance, and awareness of these things, that's all we're asking for. That's really all we're asking for, access, awareness, and acceptance.
Access, awareness, and acceptance.
2 really quick points.
Yes.
One is healthcare is not a bidirectional relationship. It is to take care of the patient. So the fact that this is even a problem is kind of mind-blowing. Second, we are not the problem. Our identities aren't the problem. Being queer is not the problem. Transphobia, homophobia is the
Yes.
problem. Race is not the problem. Racism is the problem, right? So we need to collect data, but we also have to be clear about how we're using that as proxies for what the real issue is, which is cultural, right? And it's structural bias in the way things have been built and the way things are delivered. It's not our identities that create the disparities.
Aha. I have to just share a couple very practical questions that came in here. This is like kind of nuts and boltsy stuff. What is the preferred way to call patients out of the waiting room? First name, last name, something else?
Patient last name?
Patient last name?
Patient last name?
Patient
Chambers.
Smith.
Chambers-Raney.
I think I would say first name's also just okay, but just the first name that they gave.
If you've collected
If
the
you've
preferred
collected-
name.
yeah.
If you've collected the name
If
of
you
use.
collected that.
Yeah, if
Not
you collect
legal
the name.
first name,
Well, yes,
yeah.
you should collect the name of use first on all
Right.
registration
Yeah.
forms, and then use.
Yeah.
Chastity on that?
That's exactly what I was going to say. Yeah, as
Yeah.
long as you're collecting chosen name and not
Yeah.
yelling out Robert.
Okay, so another practical question. On the topic of gendered terminology in cancer care, what would you recommend as the best practice in naming conventions for care? Naming conventions for care, i.e. in a breast clinic, women's health centers, et cetera.
Breast and chest imaging?
Breast and chest.
Breast and chest imaging. Aha.
And intervention?
Okay, because the words are often just don't work anymore, right? They don't work anymore. Okay, good. I wanted to move into an area that was raised, I think Chastity raised it first, fertility preservation and sexual health. Whether it's the kind of experiences that Paula mentioned or physicians' attitudes and so forth, or things like radiation and so forth, what are we learning or haven't learned yet enough about fertility preservation in these populations?
Can I just say something
Yes,
here?
Paul, of course.
I have talked to so many survivors who tell me the first thing they're told is, we're just going to take your uterus. Yeah. Why is that the first thing? They said that to me, and I'm like, wait, what?
What does that have to do?
Why is that the first thing? For so many colorectal cancer survivors, it's, we're going to take your uterus, and then you wake up and you're 27, you're 35, and it's like,
God.
no one talked to me about preserving anything, about what this means in my life, my sexual health, nothing. I just wanted to throw that in because it's one of the things I hear over and over and over again.
There was consent wasn't given or wasn't discussed or what?
It'll be, we took it because we had to, or we're gonna take it. It always ends up being the first thing. But it's like we need to take a step back and really include the patient in this. Talk about what that means and what else can you do besides that? It just seems like it's always the first and easiest answer.
So
I wonder if the assumption is also, as a lesbian couple, you're not using the uterus,
Well,
because
that
that was
might
the
have been
assumption,
in there,
right?
yes.
So there's that
So, lesbian couple, perhaps might people of color be more likely to have to experience that?
Yes.
Is that a possibility as
Well, I
well?
mean,
I would say yes. A lot of the black and brown ladies that are people who identify as female that I've spoken to in this space tell me it's just sort of like, well, you don't need that.
and you don't need
It's
to have
just
any more anyway.
assumed. Like, yeah.
Oh, dear. Chastity on fertility preservation, then I want to hear back as well from Mandy and Archana on this too, across the board.
I mean, I think for fertility preservation, it's been said, we need to have these conversations with every single person. I don't know that there's anything else to say. Every single person.
Yeah.
Throughout life.
Yep.
That's definitive, but we're far from it. Archana?
And understand that fertility preservation is about particular biological capacity. So you're talking about, if you have a uterus, let's talk about the preservation of eggs. Not, that doesn't, are you a woman? I don't care. I have a uterus, it functions in a certain way. I have a penis, it functions in a certain way. Where are we around utilizing the things needed to make sure that you can do what you want to do if you want to do something about having a family, biologically?
Yeah, the only thing I have to add there is just that I think culturally, again, that I've had many clinicians tell me, I just feel uncomfortable, I don't know what to say. And like, that extends to just talking about sexual sequelae or just sex period, right? Like, so, so we need to be more comfortable about talking about fertility and sex just period, as, in terms of healthcare delivery. And then the other point I think that's highlighted here is just really the takeaway in terms of, when I'm doing implicit bias training, it's like the takeaway, well, okay, there's two takeaways. One is you're gonna make mistakes if you try, right? You're just gonna, so get over it. The second is just pause when you make an assumption. Pause and reflect on, okay, I had that reaction, that went through my head. How is that going to affect the patient in front of me? And what do I want to do to be intentional to preserve the wellness and promote the wellness of the person in front of me? Because it's not bidirectional and it's not about you having the reaction in front of the patient. So how do we suspend and pause with our assumptions before being intentional about our care?
Okay. This next question follows on the suggestion, I think, that Paula made a few minutes ago about there is some upside to this. You're seeing some improvement on this. The question is, and this is for anyone who's kind of prepared, do you have practical advice for young clinicians in getting institutions and the clinicians themselves to put any of these best practices into action? There seem to be some well-intentioned administrative efforts, but they're not translating into patient care. So advice in a clinical setting. Archana, and then I wonder if we get from Memorial Sloan Kettering a view from Chastity as well. Archana?
So our research center is working on a transdisciplinary research project right now on transforming medical curriculum around sexual and gender diversity. And so one of the things that keeps coming out over and over again is that this has to get incorporated into medical education from coursework through clinical training. That it's not we'll start it here, or it'll be a unit over here, right? And so it's the idea of doing that, having that interwoven throughout at multiple levels. So it's, it can't be a unit on different, like, oh, and by the way, when you have a diverse patient, here's what you're going to do. And then, plug and play. There's no plug and play in DEI training. I think that's super important. But the other thing is, recognize that when you are willing to show your desire to learn, that builds trust with the patient. I'll just give one great example. I fired one OBGYN, found another one. And the other one was trying to talk to me about fibroids, and she had asked me my entire sexual activity history, and we had talked about all of that. And I had indicated that I'd had sex with men before, and so she was trying to get around the question, like, when you've had sex with men, she wanted to know if it hurt, right? And I was able to say to her, the phrase is penetrative sex, is that the question you're trying to ask me? And she said, yeah, that's the one. And I said, great. And we came to a conclusion. But you know what? The fact that she was trying, and I could see her saying, I want to ask this right, and I was like, what information do you want to get to? Can I help you here? Like, I'll take one step, I'll take 25, right? Like, I think that's actually true.
It's like we almost need a glossary at this point.
Or a willingness to learn.
Creating space to be open.
And we do have a glossary, by the way.
We do have a glossary. And penetrative sex is the more accurate, less gendered term, right? So like we already have that language. It's just shifting from a heteronormative, cisnormative language to using just the medical terminology.
Oh gosh, got it. Chastity wanted to add on this point.
Yeah.
I don't remember what I was going to say, but I will say something to that.
At this point, well, just from Memorial Sloan Kettering is your outfit.
Oh.
And so are you seeing anything insofar as education or best practices implementation?
Yeah. So now I remember, we're talking about making this all happen,
Yes.
right, in a healthcare environment. So I mentioned that we collect sexual orientation and gender identity data at MSK. I had looked back, and the first email I sent to a colleague about trying to do that was in 2012. We started collecting sexual orientation in 2018. And in May of 2021, I think it was, or 2020, we started collecting gender. So what I'm telling you is it's not often overnight. This is a big cultural shift. And you can't do it alone. I found myself last person standing. All the people I had emailed in 2012 had retired. And I was still plugging away. And so I'd say whoever that question came from, you need a group of folks. You need people across the organization. You need people across levels of the organization. And you need to remember that this is hard. And you need to have a network of support. And I'm going to look at Mandy for a second, because this came up on a call one time about that experience of burnout when you're doing work like this. Because I'm guessing that you're here because you're doing work like this, and I'm watching a nod over here. It's exhausting, and we need to be here for each other and pick us up when we got to know and try again.
Paula, you reacted to that. Paula, Mandy, Bláz.
I just want to say, for me, in my local community, after my surgery, which was in 2015, after I realized I was really mad, and then I had to do something with it, I became an advocate because I knew that if that happened to me in that county hospital, it happened to other people. Yeah. And Houston is my home, and whether you like how I present and who I am or not, I'm part of this community, and I wasn't going anywhere. That year, my wife and I were legally married in the state of Texas, yay, and I got her job, the HR person at her job put me on her insurance right away. Yeah. So I had a choice of what to do. I stayed at my county hospital, and I'm still there. You know why? Because 8 years later, I refused to go away. I made sure that everybody knew what happened to me there. I fired that oncologist, and I got the new oncology team at that hospital. They are inclusive, they are caring, they know what happened. I'm on a patient advisory board, and this is how things change. It's almost 8 years, but everything's different at that hospital. And I hope that just when you hear my voice, you know that this work that you do is important. And I know it takes time, but it will save lives. And so thank you for letting me say that.
Well, it sounded as though you, the patient and patient advocate, were the one to help educate the staff of the hospital and their administrative procedures.
I hope so.
Sounds like it.
Patients
Okay.
can have tremendous power. From a research perspective, in answer to the question
Yes.
pragmatically, so I was first author on an American Society of Clinical Oncology funded study where we looked at sexual orientation and gender identity in oncology practices, and what bubbled up as the most explanatory factors for institutions that did collect SOGI data were leadership, resources, specifically such as a place to store the information in the EHR, and belief that it matters to health. And so, and an illustration of that. So if you're going to collect the data, clinicians need to know where to put it and how to use it, right? An example of this, I let everyone around me know that I had been part of this implicit bias training, free hour of CME, it's freely available to you. Great, that sounds great, that sounds great. I got my boss to send out emails to 61 people who are patient-facing, and within 2 weeks, we have 33% of those people having completed the implicit bias training. That's not going to solve everything. It's a step, right? It's one step. But making something mandatory with leadership support is huge, right? The second thing I was going to say is, and I hope that you'll forgive me for picking on you for a second, but I hate it when people say diverse patients. I have a diverse patient.
Yeah,
what does that mean?
What does that even mean?
Right? So we have this, Audre Lorde talked about the myth of normal, right? We have this mythical idea in America that the norm is white, male, heterosexual, financially able, and tall, right? And everything that we refer against is, I mean, okay, so on both sides, I'm gonna get it. But like, if you think about our reference variable in so much of our research, what's the reference variable? Male, straight, right? Heterosexual. So we have to get beyond this idea that there's a norm to which we're comparing things. There may be a privileged group to which we're comparing disparities, but it's not a norm. There isn't a diverse patient. We all come with a variety of different identities.
That's how I was being facetious.
Okay, perfect.
Exactly. Yes.
Great. So I'm not kicked off your panel.
Like diverse. What does that even mean? That's all of us.
Over to Bláz.
Okay, so just a quick point, and then I want to talk about body dysmorphia just real fast for the community. But on the education piece, yes, second your comments. Like, don't just make this like 6 individual blocks for LGBTQ healthcare. Like, your hormone block should include trans-affirming hormone care, you know, your family building, family planning, not just maternal medicine or women's health, but any of the family planning needs to include LGBTQ family planning. And then for patient simulations, you need to have transgender or anybody from the LGBTQ community, intersex, differences in sex development. These need to be part of your patient simulations. And if you don't have the community,
and socioeconomic status,
and
region.
overlap, and if you don't have the community to be in like standardized patients, then you need to build ways to have that experience in a virtual way, in a module, for example. Many trans folks don't want to, you know, even for paid standardized patient visits, go through people learning how to be inclusive on them. It's just too much of a re-traumatization. So we need to build these kinds of modules. On the body dysmorphia side, and this is around the social disparity and barriers, I wanted to bring up a friend of mine who kind of disappeared off of social media for years, openly gay Black man. And you know, I had reached out, I wanted to know how he was, I hadn't heard anything. And just like a couple of months ago, he posted himself on the beach for the first time in a long time. And what he said was, I was diagnosed with cancer a couple of years ago, and I've been so ashamed with how I look in my body and the changes that have come over me. I've gained a ton of weight, and actually this is the first picture I wanted to put up of myself since that time. You know, I will speak, my own community has its own issues with body and body presentation, and looking a certain way in the gay community is a big problem and a big deal. And so, you know, this person was ostracized and really removed themselves from their community because they were so ashamed with the changes in their body that they didn't want anyone to see what they look like anymore. And that breaks my heart. And I think that's the kind of thing, if we're talking just about the social environment that we're addressing, if we're not building groups for somebody who's going through something like that, then we're missing out on really important patients who are now facing depression and isolation, anxiety. And that goes for trans and non-binary individuals as well. You might work so hard to get your body to look a certain way so that you can feel safe or be seen the way you want to be. And then something like cancer can just throw all of that away for you. And we need to be having that level of conversation or support system for patients who are facing that.
Thank you very much for that, Bláz, and it nicely echoes the point you made at the beginning having to do with isolation. I mean, that's a very important way to illustrate that. I'm going to try to do this next question justice. There's a lot of content here, and I don't know that you can answer this whole thing, but if anything piques your interest or causes you to respond, please do so. This is really getting, like I said before, nuts and boltsy on really practical questions, so here goes. How should we address the unique care for trans people who underwent genital gender-affirming surgery, trans women, skin cancer for penile inversion, colon cancer for colon graft, breast cancer? I'm not done. For intersex variations in sex characteristics, difference in ICD-10 and 11 codes. Heard some affirmation of that problem just now. Drop the hermaphrodite sex development and pseudo-hermaphrodite terms. Screening or risk assessment for germ cell neoplasm. You'll see why I kind of gave you a warning on all that. But these are practical things like, they all seem to be disconnected from how the administrative healthcare system is set up. Any responses to these specific instances?
What was the stem of the question? How do we approach?
How do we address the unique care needs of people in these situations?
I think the question is in some ways an answer itself in that there's a suspension of assumptions. Like if you have a neovagina, even though you wouldn't refer to it as that, you would refer to it as the vagina, you're not going to be looking for vaginal cancer. You may be looking for skin cancer. You may be looking for melanoma, right? Like being aware of just the basic foundations of what you're taught in medicine and applying it to the person in front of you to promote their health and well-being. I did want to say, and I did forget to mention this, that Medicare very importantly has a gender ambiguity code for procedures that may be perceived as not necessary based on the sex marker on record, and that's code 45. So if you are doing a procedure that the patient needs, but you think that Medicare might not see the need for it because of the sex marker, you can include that code. As far as I know, private insurance companies do not share that, and so I have had a wonderful friend, a good friend of mine who I love dearly, who is a physician, call private insurers up and say, okay, so you basically are telling me that you have a policy of discrimination on record, that you're not going to pay for this procedure that's required of my patient. And sometimes, unfortunately, it's extremely inefficient, but physicians have to pick up the phone and call the insurance company and make that kind of advocacy on the part for the patient, because the patient may not realize that anything can be done about it and be left with a huge bill. So I think just being aware of what barriers and obstacles and structural bias might exist for the person in front of you and trying to advocate accordingly.
Thank you. Closing question here, and I'll ask each of you to take no more than 30 seconds or a minute max on this one, okay? And by the way, we got a very good question about the U.S. Preventive Services Task Force. I don't know who asked it, but I'm saving that for the next session on policy. So we're not going to ignore the USPSTF thing. I know it's a hot issue. So this is December 2022. Let's say that it's December 2030. Each of you has remained in this field and has been aware, hyper-aware, but you've all been leaders in this field. And I pose to you that in 2030, you've said, we made it. We've done it. All of my efforts in advocacy, in research, in management, we've succeeded. What's going to be the signal to you that we made it? What's going to tell you? Is there some kind of marker, some kind of signal in there that says, that thing told me, that advance, that change told me that we've gotten to where I wanted to go back when we were at the National Press Club in December 2nd, 2022. So let's go right to left, since Mandy already started to say something about this. Mandy, or are you going to tell me it's not going to?
Now I got to think faster.
My heart just I was like, can we get there? Can we get there? I mean, I really believe that the driver of change is going to be physician representation. So if there are more transgender and more queer people that are out in oncology practice at various levels, doctors, nurses, social workers, across the board, I think that is what's going to drive change. So because we know that we listen to people that we care about, that we love, that we have conversations with, and if we have peers influencing us, that's one of the top ways that physicians change. So I would say representation in the oncology field of a whole lot more queer people.
Thank you, Mandy. Archana.
This is tough because I don't think there's an end point. I think there's a process. So for me, change would be there if the idea of having these conversations was assumptively expected in terms of what it means to train physicians. You have to take these classes, you have to do these rotations, you have to do these fellowships. Nobody would believe you that you're a doctor unless you did those things. I want to see an understanding of the human experience from a truly intersectional perspective as assumptive, that you can't, how are you treating people if you don't actually understand people, right? I would like that to be one of the questions.
So there's a little kind of overlap here on clinician and provider education, whether it's the vocabulary, I mean, there are just so many aspects that go into it. Thank you. So Paul, what would signal success to you, Paul?
I would just be really happy to see queer people being able to go to the doctors, get their screenings, scheduled screenings when they're supposed to, and they're not dying from diseases we can catch early and treat. I'd like to, in 2030, I'd like to know that Black and brown people who are in this space, who identify as queer and gay, are feeling like they can go into a doctor, get their cancer screenings. If there's something wrong, they'll have access to care. They'll get the support they need. They'll have their loved ones beside them, whoever that is, their chosen family, hopefully their family of origin, whoever they want to be there. And that whatever care they're receiving, they're getting, whatever care they're receiving, that they're getting that care from someone who sees them as a human being and accepts them for who they are. That would be success to me. I don't want anyone to miss a screening because they're scared to go to the doctor, because they're worried more about how they're going to be treated than what the screening might say itself.
Thank you, Paula. Bláz?
Admiral Levine said a lifespan of care. So in 2030, I agree, it's a process. So step one. But I want to see a lifespan of LGBTQ care, where you're not just going into a gender clinic on the youth side or a gender clinic on the adult side or one LGBTQ FQHC in your area, but that from birth, there's inclusive birth options, both on the parent side, both for the child side. As you age up, there's inclusive options. You're starting to talk about fertility preservation at early ages for people who might go on hormone blockers or have surgeries. You then go into, adolescence if you're referred to the adult side. So if you're in the adolescent gender clinic and you get referred to the adult side for your cancer care, I want to make sure that nothing is lost in between that transition, that you can continue to be gendered appropriately and the name that you'd like to use appropriately. I want radiologists who use the right pronouns, who know how to get consent about the body parts and not be surprised if things don't all match up and how they might assume. Anesthesiologists use the right name and pronouns before they're putting you under for surgery. I mean, every level of wraparound services that a patient's going to encounter on their journey need to be affirming so that we can get to where you want to get to for the life.
Thank you, Bláz. Chastity.
All right, so my signal. I've been to conferences that talk about it, but I've never been to a conference that was called Care of the Tall, Cis, Het, White Guy. So maybe what defines success for me is we're not at a conference that's called Care of the LGBTQI person.
Pretty good, Chastity.
That's so we don't have diverse patients.
Exactly.
Those are 5 great take-home points with a nice topping on it. Thank you, Chastity. Well, good gosh. In pretty soon, though not this second, we're going to take an hour-long break for lunch. We're going to reconvene at 12:45 p.m. Eastern, and that's for not only folks here in the room, but folks that are tuning in virtually. And when you do come back after lunch, we're going to hear about specific best practices from patient advocates. And this is like a lot of here's how you do it right stuff from 1, 2, 3, 4 distinguished speakers. That's how we'll enter back after lunch there. I'll add a couple things at this point. What a splendid panel this has been. Please keep in mind, yes. And I'm going to ask you to do that again in a moment. Please keep in mind that what you've just heard is a reflection years back, a status report, and where we need to go next. This is occurring in real time as there are other threats to our LGBTQI plus populations. It ain't getting any easier out there for some reasons I think we might hear about a little later on today. So the context, the environment for this is no less challenging and from day to day sometimes even threatening. So please kind of keep that in mind as we try to go forward here. I will say,
Thing. I know I have too many words, but the downside.
they're usually good,
the downside of like raising my hand too soon is that I forgot a really important point. We have not used the phrase trauma informed in any of our comments so far, and all of us are traumatized from COVID, from polarization, and then you add cancer and you add stigmatization. Like so, at 2030, hopefully sooner, I hope that every patient, regardless of who walks in the door, every patient is diverse, right? And every patient is asked, what's happened to you? Like, because we all have trauma, right? So how do we start to approach medicine in a way that's trauma-informed? So I'm so sorry, but that seemed super important.
No apology needed, I assure you. And as Mandy just demonstrated, again, if you want to hear the real deal on breaking barriers on identifying and addressing unique cancer needs of LGBTQI plus patients, you tell me if you could have done any better than Chastity Burrows-Walters, Bláz Bush, Paula Chambers-Raney, Archana Pathak, and Mandy Pratt-Chapman. Please join me in thanking them yet again. Thank you very much. We'll see you after lunch. Come on back. See you then.